My name is Dennis Chong and I'm a cardiologist at Leighton and Royal Stoke Hospital. So today, the topic of my talk is on acute heart failure. I have no financial disclosures relevant to my talk today. So we should start by defining what we mean by acute heart failure. So we generally refer to patients with a rapid worsening of their symptoms and signs of heart failure in either a patient with known diagnosis of heart failure or a new diagnosis of heart failure for which prompt medical intervention is required. So I'm going to spend the next 20 minutes outlining why acute heart failure is important, going through the steps of assessing patients with acute heart failure, as well as discussing some of the management points taken from the heart failure pathway. This is a very commonly used slide in heart failure demonstrating the natural history of patients with heart failure. And as Sarah, our patient, has described, patients often present with acute heart failure. And with the right treatments, we can actually see quite a significant improvement in their functional capacity. If we detect it early enough, we may in fact be able to prevent a full-blown acute heart failure episode. But sadly, some of our patients who are admitted to hospital with acute heart failure may die from that episode. Despite the many advances in heart failure management, the prognosis in acute heart failure remains really poor. And the National Heart Failure Audit data consistently shows over the last few years that patients admitted to hospital with heart failure have about a 10% mortality. At 30 days, this increases to 15%, and at 1 year, the mortality is about 30%. But it's not just about the mortality, it's also the morbidity. As Shabana has already outlined, acute heart failure is responsible for a huge number of inpatient bed days in the NHS per year, so approximately 1 million or 2% of the total bed days. It remains the leading cause for hospital admissions in the elderly group, and 70% of heart failure costs are for hospitalization. Patients with acute heart failure generally have significant limitations in their functional capacity. So moving on to assessment. As I think Sarah has very eloquently outlined, these patients typically present with breathlessness, which may be at rest or exertion. They often describe orthopnea, which may be increasing, and they may describe waking with breathlessness or PND. These patients often present with leg swelling or increased weight gain as a sign of fluid retention. Less commonly, patients may present with cough, and in the older group, confusion. Lethargy is a very common symptom, particularly in chronic heart failure, but also is present in acute heart failure, although it's less specific. It's important to inquire about chest pain, because some patients may have, in fact, an ischemic event that's precipitating the heart failure, as well as syncope, which could be a sign of an arrhythmia. I think it's important to explore recent medication changes. So there are some drugs that are associated with heart failure, such as steroids or non-steroidal anti-inflammatories. But more commonly, particularly in patients with known heart failure, cessation of heart failure treatments may be the precipitator. So this might occur perhaps because of a hospitalization that was unrelated to heart failure, where the diuretics or heart failure treatments may have been stopped. Many heart failure patients are on multiple medications, and they may experience side effects which can lead to non-adherence to treatment. Some patients with known heart failure have already got existing advanced care plans, and it's important to inquire about this because this will guide the approach to management. In terms of signs, patients generally either have signs of volume overload or reduced perfusion. So the three hallmarks of volume overload are raised JVP, pulmonary edema, and peripheral edema. Small group of patients may in fact have some signs of liver congestion. Tachycardia is a common sign in patients with acute heart failure, But combined with hypotension and the presence of signs of reduced perfusion, such as cool peripheries or clamminess, oliguria, and confusion, raises concern about the patient's condition. So I've taken this from the Cheshire-Mersey pathway, and really there are some red flags that should be borne in mind when assessing patients in the community. And if any of these are present, then patients should be promptly referred to the hospital. So this includes breathlessness at rest, ischemic chest pain or syncope, if there is hypotension with a systolic blood pressure of less than 90, although this needs to be interpreted in the context of the patient's normal blood pressure, a significant tachycardia or desaturation in oxygen levels, and importantly, signs of sepsis. Time and time again, we have patients that are admitted to hospital with a combination of sepsis and heart failure, and these patients generally do very poorly. In terms of investigations, these help to outline or answer the following questions. First of all, is this heart failure? So as Shabana has stated, use of a anti-pro-BNP or BNP is a useful screening tool and can be used in acute heart failure. An echocardiogram will obviously be able to help you confirm the diagnosis, although this may not necessarily be available immediately. A chest X-ray can show up evidence of pulmonary edema, and this helps us to distinguish heart failure from other important mimics such as airways obstruction disease, respiratory tract infections, pulmonary edema, or sometimes liver failure. Second question to ask is there any other concurrent illness that may be coexisting with acute heart failure? So simple panel of blood tests might help you identify evidence of infection. D-dimer will help in screening for a PE, and a chest X-ray obviously may show up evidence of a pneumonia. Next question to ask is there a precipitant for the acute heart failure episode? And an ECG is key to this. It will tell you what rhythm the patient is in. AF often coexists with heart failure and sometimes may be the precipitant factor. An ECG will also potentially show up evidence of ischemia, and that can be combined with a troponin level. However, it's important to interpret the troponin level in the context of acute heart failure because it's commonly raised. And so generally I would only suggest checking it in patients who describe ischemic chest pain or have an ischemic ECG. The echocardiogram, in addition to confirming the diagnosis, may also help show up evidence of significant valvular dysfunction, which will guide the patient's management. And finally, our investigations will also help in prognostication. So the BNP not only helps with the diagnosis, but also is associated with the patient's prognosis. So a higher level of anti-pro-BNP is associated with a higher mortality. But there are other things that we can look at, such as the sodium levels, renal function. And although we get quite fixated with ejection fraction on echocardiogram, there are other features on the echo that help tell us how the patient is doing, such as the LV dimensions as well as pulmonary pressures. So from our assessment, we can generally group patients into one of four categories. Perhaps in primary care, we often see patients who are warm and dry. So these are, I suppose, patients that are relatively compensated, but potentially shifting into a decompensated state. And early intervention in this stage may prevent a full-blown acute heart failure episode. Unfortunately, on the other end of the spectrum, patients may present to A&E in a hyperperfused state heading in towards cardiogenic shock, and the prognosis in these patients is dire. More often, however, are patients in the warm and wet category, so patients that I would typically see on the cardiology ward or patients that you may see in primary care. And these patients are, I suppose, an intermediate between the first category and the other two categories. So moving on to management, I think the first step really is to try and stabilize the patient and get them into this so-called warm and dry state. So this is taken from the heart failure pathway. In those who are critically ill, so clearly perhaps in cardiogenic shock, they will require level 2 or level 3 care, which may include inotropes or mechanical support. Patients with respiratory failure may require CPAP or invasive ventilation on ITU if they are suitable. And this, again, is a nice outline of the management of patients with acute heart failure, depending on whether they are overloaded or not, and depending on whether they are hypoperfused or not. And in general terms, essentially, patients who are overloaded should be treated with diuretics, and some of them with vasodilators, such as intravenous nitrates. And those with hypoperfusion should be considered for inotropes, as mentioned before. Note that opiates, which are often mentioned in textbooks, don't really feature here, and I would fully agree with that, because these patients may sometimes tip over if given opiates. A small group of patients who are dry and hypoperfused may benefit from a fluid challenge, but these are really a small group of patients, and I think often patients who have not just acute heart failure, but maybe something else like sepsis. So focusing on patients who are overloaded, well, if they are in the primary care, then often they are treated with oral diuretics. Some regions may have the benefit of an ambulatory heart failure unit or community IV diuretic support. So in those places, then referral to the heart failure team for early intervention is recommended. But in those without, then I think often, sometimes primary care physicians or clinicians hesitate to give diuretics for fear of causing renal impairment. But it's important to start this because you may well be able to prevent a full-blown acute heart failure event and admission to hospital. In those hospitalized, generally we use IV diuretics, and this is given either as a bolus or an infusion. And in patients who are diuretic resistant, the addition of a thiazide diuretic, such as benzoyl or metolazone, may sometimes help. In those with a low potassium, the addition of aldosterone antagonists like spironolactone and pleuronone can be helpful. In all cases, it's important to have ongoing monitoring of the patient's blood pressure as well as urine output. If they're an inpatient, then check of their daily weights as well as fluid balance, and clearly check of their urea and electrolytes. We sometimes encounter problems in patients who are overloaded, not uncommonly those with concurrent acute kidney injury or a reduced eGFR, and there can sometimes be this reluctance to give diuretics in that case. However, if the patient is truly overloaded, then often we will see that as the patient has a good diuretic response, the renal function will either dip slightly before it actually improves as renal perfusion is improved. However, if there is progressive decline in renal function, then it's important to consider renal replacement therapy and involvement of the renal teams. Patients who are hypotensive may also may need to be treated cautiously. So this could be just simply a reflection of the patient's normal low blood pressure. But if there are signs of hyperperfusion, and when there is perhaps some doubt, checking a blood gas may sometimes be useful if it picks up metabolic acidosis or high lactate levels. And I found that using an infusion in these patients is perhaps better, gives a smoother effect compared to using IV boluses. In all patients with suspected acute heart failure, they should have an echocardiogram performed as an inpatient, preferably within 48 hours. In those with known heart failure, if you suspect a change in ejection fraction or significant valvular impairment, then they should also have an inpatient echocardiogram. All patients with a primary diagnosis of acute heart failure should be managed on a cardiology ward. And in those that can't be managed on a cardiology ward, they should have in-reach support from the local heart failure specialist team. The reason why this is that time and time again, the National Heart Failure Audit demonstrate that patients managed on a cardiology ward or have heart failure specialist input do better than those who don't. I think it's important from the outset that we think about the end game. So a lot of our patients admitted with acute heart failure are elderly and have multiple comorbidities. So we need to think about, what is this patient's ceiling of care, and that should include whether the patient is suitable for ventilation, whether that's non-invasive or invasive, whether the patient is suitable for inotropes, because at the end of the day, there's no data to support inotropes for improving prognosis in acute heart failure. In perhaps younger patients, mechanical support may be a possible option, but in a lot of patients, this is not a viable option. And again, renal support should be considered in those that are appropriate. We know that the prognosis in acute heart failure is poor, so we should really think about the patient's resuscitation status, and in those with an ICD, whether ICD therapy should be turned off during that admission. Some patients, unfortunately, it is clear that when they are admitted to hospital that they are dying, and palliative care input is important in these patients. Finally, it goes without saying that these important discussions must take place in conjunction with the patient and their family. So once the patients are hopefully stabilized and in a warmer and drier position, then we can start to think about the treatments that we know make an impact in the longer term prognosis of the patient. I won't go into much detail in these agents because I know that other speakers will, I'm sure, delve into it. But just wanted to highlight that for patients with reduced ejection fraction, we should take the opportunity during the hospital admission to start them on key treatments that we know makes a difference in the prognosis, and that's the beta blockers, RAS inhibitors, and aldosterone antagonists. These key treatments are recommended by NICE, and you can see here from the National Heart Failure Audit that patients on 3 of these agents have a survival of 80% at 1 year compared to 50% for those without any of these treatments. SGLT2 inhibitors are the 4th agent that haven't quite made it yet to NICE guidelines, but is within the ESC heart failure guidelines. And importantly, this is emerging as a viable treatment across the heart failure spectrum, so not just in reduced ejection fraction heart failure, but also in the preserved ejection fraction heart failure group. And there is, in fact, a trial called the EMPULSE trial that is yet to be published but has been presented that shows that empagliflozin initiated at day 3 may have an impact on patients' prognosis. So pre-discharge, it's recommended by NICE that patients should be stable for at least 48 hours. By that, they're off IV diuretics. Some centers may have good community support or ambulatory heart failure unit, whereby these patients may be feasible to reduce their length of stay. All patients should receive heart failure education prior to discharge, and this should include about self-management as well as, importantly, the contact details of the heart failure team. Patients should be given the opportunity for referral to cardiac rehab, and importantly, should be seen within 2 weeks of discharge. But this, as we know, is a challenge. And finally, we know that acute heart failure events are significant and portend a poor prognosis. So we should think about advanced care planning in these patients. So in summary, acute heart failure is associated with significant mortality and mobility, and prompt treatment is required. In assessment of patients, we need to determine their fluid volume status as well as their perfusion status. And finally, all patients with acute heart failure should be referred to the local heart failure team. Thank you.